So our final speaker this afternoon, this is a real honor for me to introduce this individual. I've known Dr. Ebersole both professionally and personally for over 20 years. So it's really a pleasure for me to have him here today. Dr. Ebersole graduated from Temple University and received his PhD from the University of Pittsburgh. Following a postdoctoral fellowship at Forsyth Dental Center and Harvard University School of Dental Medicine, Dr. Ebersole accepted a position at the University of Texas Health Science Center at San Antonio School of Dentistry, where he was a professor in periodontics and microbiology. In 2000, Dr. Ebersole joined the University of Kentucky College of Dentistry as the Alvin L. Morris Professor of Oral Health Research, Director of the Center for Oral Health Research, and Associate Dean for Research. In 2017, Dr. Ebersole assumed the role of Associate Dean for Research and Professor in the Department of Biomedical Sciences at the University of Nevada, Las Vegas School of Dental Medicine. Dr. Ebersole is a prolific dental scholar with over 300 publications, reviews, and book chapters in the area of microbiology and immunology of periodontal disease. He has received several awards for his work, including the Mentoring Award from the University of Kentucky Center for Clinical and Translational Sciences. And in 2011, Dr. Ebersole was elected president of the American Association for Dental Research, and in 2016 was appointed a university research professor at the University of Kentucky. Dr. Ebersole will present the use of biologic diagnostics for precision oral health, what role in the public health sector. Please join me in welcoming my colleague and friend, Dr. Jeffery Ebersole.
Okay, hopefully my voice will hold out here. I'm dealing with a bit of a cold I picked up a few weeks ago after visiting grandkids. They're sort of disease harbingers kind of thing there. Well, I'm going to change paths a little bit from the last talk that Kimon gave focusing on dental caries, because most of my career has really focused on the idea of the immunobiology of periodontal disease. And I hope through my presentation today, which I will show you a variety of different research vignettes of study designs and data that we have gathered, trying to make a point with each of them, that I hope you will see commonality and an overlap with some of our previous speakers and some of the thoughts that they had posed relative to where precision dentistry fits into the public health sector. Now, my topic and area will focus on sort of the biologic side of that. So the idea of how do we identify certain markers, certain characteristics of the patients that might help us in that prevention mode and potentially even treatment decision mode as well. So periodontitis, again, in some cases I may be speaking to the choir here, but we're talking about a disease that is associated with bacterial biofilms that accumulate in the oral cavity. We know that these differ in health and then they change dramatically. In disease, again, a similar dysbiosis as Dr. Kavaris talked about. Interestingly, in periodontal disease, more or less as in dental caries, we're really talking about organisms that are normal members of the majority of the oral cavity of the majority of the population. At some point in time, they have the capacity to express themselves as opportunistic pathogens in this disease. So it's a very different thought process of how the host long-term interacts with these organisms. We know that this disease process is triggered by this dysbiotic change in the ecology, so we're not talking about a single etiologic agent that causes periodontal disease. It is an ecology change that allows this to happen. The other facet that we've learned over a number of years, and this was brought out in some of the earlier talks, is that the clinical presentation of the disease is really not directly assigned to factors, virulence, toxins in the microorganisms, but in fact it is the host immunoinflammatory response that is trying to control this ecology, that is trying to control this dysbiosis, and periodontal disease represents a dysregulation of the homeostasis and almost a collateral damage of the normal host response to this microbial ecology. The last point I wanted to make here, and as we go across the years or decades, the idea that the entire population is not susceptible to periodontal disease. There are high-risk subsets in the population. We know that both in the onset of the disease, the extent of the disease, the severity and progression of the disease. However, we don't really know how to effectively identify who those folks are going to be. So that's an important concept when we think about precision dentistry or precision public health. And I put this down here. Stephen Wright is one of my favorite comedians. Many of you probably know him, some others don't. He has a very weird perspective of seeing how the world is, and I thought this was an appropriate thought process for this group. If we look at the epidemiology of periodontal disease, this is a publication that came out of JDR a few years back. We see an increase going from 30 years over to 80 years of age here, a linear rapid increase in the prevalence of moderate periodontitis. We see severe periodontitis increases with age, and in fact, mild periodontitis tends to decrease a little bit with age. Others, and we've just done this recently in a study that I'll describe to you later on, looking at the exposome in periodontal disease, but clearly males tend to be increased in susceptibility to disease. Minorities, including Hispanics and African Americans, clearly are at greater risk for disease. And then as one ages, as shown here as well, there's an increased susceptibility to disease. So we have a variety of parameters that we know exist. We don't know exactly what the underlying basis for why those differences occur. One of the other things that I wanted to bring out, because it really sort of focuses on the public health side of this, is the general lack of the community. And we found this out when we interacted with chambers of commerce across the state of Kentucky and tried to have them understand the importance of oral health in the population and to them as business people. And what is often lost on them is the hidden cost of these infections across a lifespan. It's not just dental caries in kids. Of course, that dramatically affects a whole variety of the lifestyle and success of the children as they age. But from an employer standpoint, it dramatically affects employees, including high out-of-pocket costs, which still are probably 60 to 70% of the cost of dental services are out of pocket. Lost work days, impact of caregiving. If a child has a dental disease, the parent has some responsibility there. And even if they are able to come to work, the loss of productivity there. It goes on to the employers having cost associated with dental benefits and treatment, and again, even going into retiree costs, which then show up at the senior citizen retiree level. So the dental disease, and again, I'm focusing on perio, has a lifespan impact on the population, and it affects the individual as well as the economic basis of our society, and we need to think about that as a public health issue. The other thing that we tried to make a case for them, and I'll bring up later on in my talk today, is that we can't isolate periodontal disease simply to the oral cavity. Yes, it does cause a variety of problems, and it causes issues associated with the individual's oral health and their view of themselves. But we now know there's quite a bit of literature regarding the oral systemic linkage. The mouth is connected to the rest of the body, as you've heard before. We know that the disease has an altered bacteriology and inflammation. We know that the bacteria get from the mouth into the blood system and circulate in the blood system. We know that these bacteria, once they're in the blood system, they upregulate systemic inflammation, which is not a good thing. And we now have a variety of some stronger, some not as strong, associational relationships of chronic periodontitis with risk of diabetes and lack of ability to control diabetes, cardiovascular disease, including atherosclerosis and myocardial infarction, impacts on adverse pregnancy outcome and the growth of the fetus, and most recently, more and more data being gathered on the role of, or the potential role of periodontal disease in risk of expression of Alzheimer's disease. So it's not just something happening in the oral cavity of the people, of their employees, it's an impact on the overall health of the folks here. Again, emphasizing the public health nature of this oral disease. So what do we deal with when we think about the disease, or what kind of things do we try to look at? Well, we're really looking at the bacterial side of it and this dysbiosis, and the host response side of it and this dysregulation, and trying to understand when and how does this become out of balance at the individual patient level? Why is that happening? And how different is that from one patient to another? Now, as I said, most of my emphasis today will be on the host response side of that. It is not to minimize the importance of the characteristics and changes in the microbiome, because they are the ones that are driving this dysregulated immune response. So there was, I think Dr. Slavkin put up a more simplified slide of this early on. This is adapted from Kornman a number of years ago. So much of periodontal disease is out here at this end. We identify the clinical symptoms. You have disease. You're sitting in my chair, whether it's a general dentist or a periodontist. Let's do something about it. But what is lost is everything that happened and the time frame with which that happened before. We have this accumulation of biofilms that trigger immune responses. We have a feedback back and forth between the host and the microbial biofilms. In the end, if the host is unsuccessful, this set of molecules stimulates the clinical symptoms of periodontal disease: soft tissue destruction, which is a biological process; resorption of alveolar bone, which is a biological process; and in the end, we have the clinical symptoms. There are modifiable risk factors associated with that, things like smoking and a variety of other environmental challenges. And then there are non-modifiable risk factors, including genetics, and one might even think of age as a non-modifiable factor here as well. So this gives us a lot of opportunities to target different potential biomarkers, biological markers of this process, and ask questions about how they might fit in, helping us understand the disease process, the risk of the disease in a particular patient or patient population. So what I'm going to focus on then is a variety of studies that we've done, and again, I'll try to make sure that you walk away at least understanding a little bit of the points that we try to make on these biological diagnostics in periodontitis. So this is one of the challenges that we have in the field, and that is the clinical measures and an assignment of disease in perio is not particularly good. We have a measure of bleeding on probing and frequency of sites bleeding on probing, and if they're sort of less than 20, they're considered healthy, and if they're greater than that, they could be gingivitis or periodontitis. We don't really know, it's just inflammation. However, if we add to that pocketing, so tissue destruction, again, generally if it's greater than 3% of the sites, or clinical attachment loss is greater than 3% of the sites, it transitions one's clinical categorization from gingivitis to periodontitis. If you look at 10 perio studies as to what they're using as diagnostic criteria for periodontal disease, you'll find 10 different criteria in the literature. So this is really rather not very fulfilling in trying to understand at a public health level how to deal with this disease and predict the progression of disease. So if you look back in the literature over many, many years, there were lots of studies looking at various different markers in blood or in saliva, trying to diagnose periodontal disease from health. Well, yeah, they were very successful, But how many times do we really need a biologic diagnostic to separate periodontal disease from health? Everything is different. It's not a problem. Clinically, they're different. So what we focused on is saying, well, how might these biomarkers actually be useful in the hands of the in the hands of the clinicians to help them do something they can't do now? So again, we're talking about things like looking at risk, because once a patient has the disease, the risk is now gone. They already have it. Potentially disease detection, if you're getting into a population that doesn't necessarily have access to the professional dental community, how might we involve that? Indicators of a disease process and the risk of disease progression. Identifying a patient once they have progressed, might we be able to do that, because that's not easily done clinically. And again, while clinically we can define a responder to therapy out 6 months or a year, don't we want something earlier, if we're talking about public health issues here, to be able to say to the dentist and to the patients, we've tried this treatment, it's not working, let's try something different. So we've adopted a number of different markers, and you look in the literature, some of these overlap with other studies. Some other studies have used different sets of markers, but these sort of represent a range of inflammation, soft tissue destruction, and bone resorption, which are all hallmarks of the periodontal disease process. So the first thing that we did was actually identify changes in these biomarkers, or do these changes in biomarkers tell us anything about the transition from gingivitis to periodontitis? Right now, clinical measures only tell you once you have the disease. We know that gingivitis precedes periodontitis, but we don't know who within that gingivitis population will actually progress. So the idea of who's going to do this, go to gingivitis. In those gingivitis patients who are going to respond well to standard prophylactic therapy, go back to health, or in fact go on to periodontitis. There is little to no literature biologically on that process. So we looked at these various markers that we had defined in periodontal disease patients, and I'll get to that in just a second, and we said, well, do they help us understand anything about the process and the likelihood of gingivitis patients potentially being at risk for disease? And what we found, comparing gingivitis patients, this is saliva biomarkers, to healthy individuals, classic markers of periodontal disease really showed no difference. So gingivitis patients really don't have elevated measures of most of these periodontal markers that people have looked at before. But in fact, we did find two that were significantly elevated in gingivitis patients versus healthy individuals. So we found a couple markers that were interestingly unique in the gingivitis. We also found that once we treated the gingivitis patients, so we now took them back to clinical health, in fact, they still remained elevated in their saliva with these two markers. So they look clinically healthy, but in fact, biologically in the saliva, they were not healthy individuals. Well, it turns out, which is what is not shown in this population data, that this really represents about a third of the gingivitis patients. 2/3 of them responded very well, went back to health. 1/3 of them did not. What's going to happen to them? That's the question that we have to ask. Are they the ones that are at greatest risk for progressing to periodontitis? If we want to think about a public health approach, and we can identify those early processes, those individuals who are in early processes of moving to periodontal disease, we would have something that would be very valuable. And that's actually shown in this slide. So this is a histogram of levels of IL-6 in periodontitis patients in black, and in gingivitis patients in red, and MMP8 down here. And what you can see is most of the gingivitis show up way down here on the left-hand side, not much of these. But we have this group of gingivitis patients who actually show a biological pattern more like periodontitis patients than the rest of the gingivitis patients. If you look at the literature, no one knows what's going to happen to them down the road. So studies need to be done to actually define what their future risk is. So in summary of sort of this vignette, we have these gingivitis markers that are different than in periodontitis generally. We have this heterogeneity of these patients. They clinically are grouped the same, but biologically there's some differences there. And the literature in perio generally doesn't address that concept. We had this subset of gingivitis patients that showed a salivary biomarker profile that was more like periodontitis. So again, the question that we haven't asked yet but needs to be is what is the clinical future of this subset of patients? So if we then move on to perio, as I mentioned to you, we and many others have done studies that identify a variety of markers that are significantly different in periodontal health from periodontal disease, dramatic differences in them, although not everything is different, so there are some things that don't change. So we do have a finite number of these that we have the opportunity to explore. We ask a question, and this is a study to represent that. If you look in the literature, and a lot of the concerns of salivary biomarkers were based upon very early biochemical studies saying tremendous fluctuations day to day in salivary components, diurnal fluctuations in salivary components, all of these other confounding factors, which if they were true for what we were looking at, would make salivary diagnostics almost not useful, because we couldn't collect the sample from every patient at the same day or whatever. So what we did here is we took a group of patients, this is about 30 patients, and we took a sample of saliva every other day for 2 weeks. So we had 6 saliva samples gathered over a period of 2 weeks. And we analyzed these 3 markers, IL-1 beta, MMP8, and IL-6, which we found interesting in perio. This is the levels in the perio group here, so we see the majority of them responding and showing fairly high levels of this. This is the repeats of the saliva among these individuals here, which showed us or gave us confidence that there was fairly little within subject variation, at least over this period of 2 weeks, in these salivary biomarkers. Interestingly, to show you sort of one of the power of these kind of things, we had these 6 points here, or I'm sorry, there's 7 points, right? No, 6 points here of this elevated IL-6 in a healthy patient. We thought that was rather odd. Well, we got that patient back in, and the clinician missed 3 5-millimeter pockets in that patient. So, in fact, he wasn't healthy, and this level of response was consistent with that. But what it did is it gave us confidence that in a cross-sectional way, if we sampled saliva and did these analytes in it, we could be fairly confident that that was representative of that patient's characteristics, whether they be health or disease. We also found that if you put multiple markers together, in this case IL-1 beta and IL-6, we could find a very high relationship. Here's the disease, here's the control, with an area under the curve of about 98%. So quite robust in being able to discriminate health from disease. We also had the ability within this population to ask the question about, well, how early do we see these changes in markers? Again, if we're looking at prevention, the earlier we can identify the changes, the better off the patients are going to be. So in this case, we actually were looking, this is a representation of IL-1 beta, and its expression related to bleeding on probing, its expression related to pocket depths of greater than 4 millimeter, and its expression relative to more severe disease pocket depths greater than 5 millimeter. And basically what this was able to show is that these salivary analytes changed fairly early in the disease process. So in this case, if we had about 15% of sites with elevated bleeding on probing, IL-1 beta was elevated in a highly significant fashion. If we had 9% of the sites with pockets 4 millimeters, it was elevated. And in fact, if we had pocket depths of 5 millimeters, less than 3% of the sites in the mouth had to be diseased, and we would see these changes in the salivary biomarkers. So we could see this early in the process rather than once the disease is very rampant within the individual. We could also find that these biomarkers would respond to therapy. So if we went in and we treated the patients, in this case we had a group of patients that we looked at over a period of 6 months. This group only received oral hygiene. These were all generalized periodontitis patients. So oral hygiene and scaling and root planing. What we were able to show is that scaling and root planing dropped these salivary biomarkers, IL-1 beta, MMP8, but not all markers changed. So there was some specificity that in fact therapy was being reflected in the salivary biomarkers for these patients. The last one, or the most recent one that we did, was actually asking the question, if we take a group of periodontitis patients, how do we know who within that group is actually going to show progressing disease? And in this case, we did a study in which we followed these generalized periodontitis patients over a period of 6 months. We measured a variety of serum biomarkers, salivary biomarkers, and bacteria in these patients. And the question was, could we predict the ones that were going to continue to progress? Yeah, there we go. So when we did this analysis, and this is a cluster analysis of the outcomes of this whole range of about 27 different biomarkers, we were able to effectively cluster 2/3 of the patients, generalized periodontitis patients, that were going to progress, even in spite of scaling and root planing. So these were patients that were going to continue to progress. Again, there's no clinical tools that we have available at this point in time to help us understand that. So this is a way of trying to focus how do we identify that group earlier. There was a presentation, or one of the parts of the presentation earlier today was using a variety of statistical approaches to help answer these questions. And this is just a representation in this group using sort of classic single univariate approaches as opposed to machine learning type of approaches and modern statistical analyses, which dramatically increase the sensitivity of how these biomarkers could be used. So it's not simply a matter of analyzing the markers, and it's not a simple matter of identifying the patient population, but also using a more sophisticated approach to actually analyze this relationship. So our conclusions in periodontitis were that selected biomarkers are indicative of the disease. We had these gingivitis patients that showed patterns that looked like periodontitis, which I mentioned from before. We have now identified thresholds of these biomarkers that relate to severity and extent of disease. We know that combinations of the biomarkers increase dramatically the sensitivity. We're now working to try to also increase the specificity of that. That's a little bit harder to deal with. We know that the markers are stable as long as the disease continues to be there. They respond to periodontal therapy, and they can predict the likelihood of progressing disease. All of these, we believe, paint a picture of saying these biological markers may very well provide some opportunity to improve the early diagnosis, the early intervention and prevention of periodontal disease at a more public health level. So sort of the last part of the talk here was the idea, well, periodontitis doesn't exist in a vacuum. We know clearly that it contributes to systemic diseases, so I wanted to show you a bit of our studies relating these two and how the biomarkers might be useful. So the first is relating salivary biomarkers to acute myocardial infarcts, so heart attacks. So we were able to gather a large group of patients that came into the emergency room with acute coronary syndrome, presumably or presumptive acute myocardial infarct, as well as control individuals that actually came into the emergency room, which is about 2/3 of patients with chest pains having nothing to do with a heart attack. We attempted to do a biomarker discovery. We started out with about 40 biomarkers that had been reported in the literature that were related to heart disease. And we analyzed these in the oral fluids to say, well, if we don't want to do this in serum, does saliva help give us any information? So from this original set of 40, we were able to narrow it down to a panel of about 7 markers. Some of them are ones that are normally part of the cardiac panel that people run when they go into the emergency room. Of course, CRP we're all aware of relative to the population-based nature of measuring that inflammatory marker. But we were able to identify a profile of salivary biomarkers that gave us a high sensitivity of identifying a patient having an acute myocardial infarct, and we could do this detection within a period of about 30 minutes or so at the chair side, which is very different than sending blood off to a lab somewhere. When we actually then took that data, and this was presented, or this model, using a classification regression tree analysis, which takes all of the variables you're looking at and says, well, who's the most important? How do we separate these patients as we go down to identify them? And within the heart attack population, about 2/3 of the patient have what's called non-STEMI heart attacks. In other words, they have an EKG that is negative. So the only thing that it tells you about their AMI is laboratory findings. So what we found using our salivary diagnostics is if we take the EKG as a starting place, which is what the cart selected out, we have this positive group here, which are called STEMI, or ST wave identified heart attacks. The ones that do not show an abnormal EKG, if we found elevated salivary C-reactive protein, we could identify a very large proportion of those AMIs. Those with lower CRP but high MPO, which is myeloperoxidase, we were able to identify a very high proportion as well. So again, thinking about how might we use this biological fluid related to detecting systemic diseases as well. I already talked about that. We've also done a recent study in which we looked at these biological diagnostics in Alzheimer's disease. Let me see there. And what we were able to identify here, so we took a large group of individuals that were followed over a long period of time at our Alzheimer's Disease Research Center. So we had samples of serum before they were identified as Alzheimer's disease, so pre-AD, and then after they were diagnosed with Alzheimer's disease. And in this case, we just asked the question, do Alzheimer's disease patients show infections consistent with periodontal disease? We did not have the clinical evaluation of periodontal disease in these patients. And what we're able to show here was this rather significant and dramatic elevation in antibodies to multiple of these periodontal pathogens. And they were all up post-Alzheimer's disease diagnosis, but the exciting findings was their elevations pre-diagnosis of Alzheimer's disease. So before the disease was manifest clinically, we were able to show a likelihood or that periodontal disease might contribute to that process. In this case, we're addressing one of the other systemic confounders, and that is the impact of periodontal disease on adverse birth outcomes, and in particular linked into gestational diabetes in this study. So in this case, we took a group of women, and they were categorized into gestational diabetes with periodontitis, without periodontitis, or just having periodontitis and not gestational diabetes. Of course, they were all pregnant women. And when we looked at their clinical presentation, what we found is really not a whole lot of difference. Those with periodontal disease clearly had greater mean pocket depths and greater clinical attachment loss, but whether they had GDM or not really didn't matter. However, when we went to the next stage and we said, well, do we see differences in potential risk for adverse pregnancy outcomes in these women, we started to see some differences. So this is a measure of a complex of systemic inflammatory mediators. So here's our GDM PD negative group with a very low level here, and if we go to the GDM positive periodontitis positive, we see this significant elevation in this range of inflammatory mediators. We also looked at antibody to a variety of different oral pathogens, and what we see is selected oral pathogens or antibodies to selected oral pathogens were quite consistent with women that had gestational diabetes and periodontitis. Again, systemic manifestations of the oral disease in these women. The last thing we did is we went in and treated the women with periodontitis, and what we found is about 2/3 of these women responded quite well to standard non-surgical therapy, improving their periodontal disease. However, we found about 1/3 of them that were non-responders. And it turns out that the non-responders had greater disease, periodontal disease, when they started out, and they had significant elevations in these antibodies and inflammatory mediators. So again, markers of prediction in the lack of therapeutic response in these women, focusing on how do we improve prevention and outcomes of disease. The last one I think I have in the data set here is a recent study that we did with metabolic syndrome patients. Again, once they have diabetes, we know they are at risk for periodontitis and that periodontitis complicates their diabetes. So we said, well, what if we get them earlier? What if we get them just at the stage of having this metabolic syndrome, which is linked into 5 key features: large waist circumference, high triglyceride levels, reduced HDL cholesterol, increased blood pressure, and elevated fasting blood sugar. All of these are a combination that will increase dramatically the risk that these patients will transition to type 2 diabetes. And what we found in these patients, again, they are not diabetic at this point in time. If we group these patients into those having few of these factors for metabolic syndrome versus those that have multiple factors for metabolic syndrome, first of all, those with multiple factors have significantly fewer teeth already, even before they have diabetes. If we rate their oral health, we see a dramatic increase in poor and fair oral health in the metabolic syndrome individuals. We also see lower levels in serum of a protective factor in the disease, adiponectin, and increased levels of a risk factor of inflammation in the serum, and we saw the same thing in saliva. So we see a systemic manifestation of this poor oral health and a local salivary biomarker detection that confirmed that. So the last one I wanted to touch base with, and that is, it came up in some of the earlier discussions, is a recent study that we did looking at environmental factors in periodontitis. And we heard the presentation and that Dr. Slavkin was talking about epigenetics. Something drives epigenetics. And what we were asking is, in perio, could we identify various environmental stressors for the patient population that might help drive these epigenetic changes that have been identified? So, So in this case, we did an environmental-wide association study that's been, the model has been published before. So we were looking at the exposome. A lot of folks have looked at the genome side of it, but the reality of the disease susceptibility, it's a combination of this exposome and genome that would alter the susceptibility or resistance of the patient to periodontitis. So we took NHANES data from 1999 to 2004. They measure 156 environmental factors, all different kinds of things. Toxins in the environment, as well as blood nutrients, so some potentially good things as well as bad things. And we found a list out of this 156 of about 40 that clearly were significantly elevated in periodontitis patients. One of the ones that showed up at the top, which was brought out earlier on with caries, was lead. We showed highly significant differences both in smokers and non-smokers, so this is not simply a smoking kind of thing, but we saw things like phthalates and PCBs and a variety of these, but not everything. It was a very targeted group of them. We also found some that were actually quite protective. Cis-beta-carotene, for example. Vitamin D was another one. Folate, blood folate was another one. So we see these environmental challenges or potentially environmental protectors in the periodontitis population. When we did a card analysis of that within our population, what we found, and some of these was very comforting based upon the existing literature, the first cut was race. Minorities were at greater risk than whites. We know that from the literature. The next level here in the minorities was a high or low blood level. If the blood level was high, and we looked then, the next one came out to be age, so the older patients with high blood levels had almost a 3 to 4-fold greater likelihood of having periodontitis. We saw the same thing in the white population with blood levels in which it was 3 to 4-fold higher. So again, the idea that these environmental stressors that are present throughout a lifespan will contribute to the disease process is something that we think is rather novel relative to the data that has been available. So it's not host biomarkers, but biomarkers of environmental challenges. So what are the public health opportunities if I think about how this links into sort of the topic of the conference? Well, one, the idea of point-of-care diagnostics. Can we actually identify certain of these things in the real world, not necessarily in a dentist office? Potentially these diagnostics being done in non-dental locations, physicians, public health departments, FQHCs without co-located dental contingencies. Could it be something that would be a personal over-the-counter diagnostic, something that would help empower the patients to better understand the biology of their disease? Could this type of approach emphasize the idea of oral health as a wellness empowerment, not a disease that needs to be fixed, but how do I help prevent that from happening and improve my not just systemic, but oral health wellness? And that the idea that these oral biomarkers may provide some early marker of systemic disease risk as well. So the whole thing bases upon, and what the very first speaker did today, the idea of earlier intervention and prevention. So right now we have a fair lack of a robust treatment toolbox for periodontal disease. Everybody gets more or less treated the same. So the question is, how do we involve things to actually prevent that from happening? Hopefully down the road, that toolbox for therapy will become more broad, but it's not very broad right now. Ooh, I didn't know it did that. So one of the point of care thing that we've been working with, and I'll show you a couple examples here. One is a box here. It can actually be put into a dentist office or in a hospital emergency room, and saliva can be collected. It put into this little microfluidic device here, stuck into the machine. It gives you presence and levels of various biological markers in the saliva, and this takes 15 minutes to get. So it's a very rapid kind of thing. But it does require this machine, and it requires this process. So there's also other approaches. This is one of ours in which we've used lateral flow chromatography. This is sort of like a pregnancy test, except it's for MMP8 in saliva. We can generate the presence of detection of MMP8 in saliva within about 10 minutes, and that is abnormal in periodontal disease. We're working with this company, Intelligence Optical Systems, which also use lateral flow, fluorescence hooked to a phone that can do the same kind of thing in a much more sensitive way. And some of the markers that we're analyzing, we need to increase the sensitivity. So there are strides being made in implementing the idea of point-of-care devices for these markers. So the future, again, my buddy Stephen Wright here, we have to do something not just to sort of replace the idea that we can't get your car working quite right or your body working quite right. So we talked about marketing today. We have to continually emphasize that dental disease, including perio, is a public health problem. It's not an individual problem to pay out of pocket to a dentist. It adversely affects individuals, and when we get to the communities and the businesses, it affects society and their communities. It's not just the individual's problem. It can contribute to long-term economic drain on the community and lack of productivity, lack of opportunity for the people in that community. There is the idea that if we can improve early identification and intervention for oral diseases, and if this can happen in varied venues, then we're making real inroads into changing the trajectory of this disease in the population. And finally, we need to be more cognizant and figure out how to do this much more robustly of linking dental care and improved oral health with general health, and these diagnostics that are linking these two together, even using saliva as a biological fluid, improves that, the concept that dentistry is part of the overall health of the population. So with that, I just want to thank this large group of individuals who've been involved in these studies at the University of Kentucky, as well as our collaborators, including some down here in San Antonio, and the funding agencies for a variety of different grants that help support this research, and be glad to answer any questions. And so forth. That's actually part of the strategy that we're trying to do. The first part, not as much the second part right now, but the first part, and that is how can we use this to help direct most efficient therapeutic approaches to it. And we've interacted with Delta Dental on a couple of these things. Now, some of you may be familiar with the Delta Dental foray into the IL-1 genotyping, and that did not go so well. The reason it didn't go so well is the insurance company, or people within the insurance company, decided they would use that biological indicator to provide less therapy. Did not go over very well. Didn't even go over very well with their employees. So what we're trying to work with them is saying, you don't go in with that idea. How do we provide less therapy? How do we provide the appropriate therapy? And that has to be done yet. We're not there yet, but that is a critical point. Yeah. Thank you.
Thank you for the presentation. Very interesting. Kept me awake. So you've got a lot of biomarkers there, things in the blood or wherever, and have you been able to look at how to change those, and does that change periodontal disease?
Okay, so I guess part of the answer is if we in fact do change the clinical presentation of disease through therapy successfully, we do change those markers. Yeah, okay. That's a harder question there. So that if in fact we do something in which we focus on the biological markers, either as a group or in concert with the standard periodontal therapy, does that improve or lower the likelihood of future disease, sort of? We have not done that yet. I think one of the things, and I was talking to the VP for the Delta Dental Foundation, and we were proposing a study to look at these specifically in a type 2 diabetic population. And he said, this is great information. I really liked all of these markers and the description. We said, so what? What do we do once we have all of this? And I said, well, part of the problem that we're dealing with is the lack of sophistication of our treatment options for the periodontal disease patients. So that we might find these biological differences, but if you treat them all the same, so what? So what I told him is I said, well, if in fact down the road we want to increase our toolbox of opportunities to tailor the treatment, we better have some data and evidence to support that. So it's a little bit of a chicken and an egg, but I look at other chronic inflammatory diseases, inflammatory bowel disease, rheumatoid arthritis, psoriasis. They're being treated with monoclonal immune modulatory molecules for chronic inflammation. Many of the factors are the same in periodontal disease. So down the road, is that something that needs to be brought to the periodontal community? Likely not systemic administration like in those diseases, but delivering it locally to where it is needed. we'll need some evidence to help support that happening. So that's sort of, that would eventually get to the kind of question that you're asking, I think.
Thank you, Jeffrey, for a very nice talk. Do your data or your gut feeling support the existence of that hyperinflammatory trait that some folks will produce hyperinflammation for, you know, less microbial insult, and that may be the common denominator between perio and diabetes, MI, pregnancy outcomes, that the relationship is really vertical and not horizontal in a way, or to some degree vertical and not horizontal.
Yeah. I believe our data are consistent with the concept that there are hyperinflammatory responders. We don't have the microbial data to support the other part of your question, and that is, can even lower numbers of microbes drive a greater response in those patients? That we don't know. What we do know is they have a greater response. We do know that the generalized patients that continue to progress do not respond to therapy, and their inflammatory mediators do not respond either. They start out higher, they stay higher than the responders as well. So I believe there is that hyperinflammatory phenotype of patients. Whether that's related somehow to the characteristics, the quality of the bacteria that they have, and or the quantity, we just don't have that data yet. But it is consistent with what you guys have reported in the past, I think.
Maybe naive on my part. There's a biological fluid of blood and a biological fluid of saliva. And is it a fair assumption that the same biomarker that you detect in saliva is also going to be elevated and detectable in blood?
Yeah, theoretically that is true. And we know because we're focusing in saliva on whole saliva, so there's gingival crevicular fluid components in there, yeah.
So I'm just thinking that if I'm 65 years of age and older and I have several chronic diseases and disorders that are being managed, and as a consequence, my biology is pumping out these markers in my blood and vis-a-vis my saliva, how do you discriminate whether the perio treatment is for the mouth or for the rest of the body?
Yeah. The way we addressed that is we took individuals with other types of chronic inflammatory diseases, IBD, rheumatoid arthritis, and without periodontitis. Okay? So did they have a higher level of salivary markers than the normal population? Yes. But nowhere near what they have when they have periodontal disease, 3 to 4 times elevated with periodontal. So there is a dramatic additive, if not synergistic, value that detects there. But you're right, that background of age and chronic inflammation, that is detectable in saliva, but in the absence of periodontal disease, it's still quite a bit lower.
Thank you for a great presentation. First, a comment. I think you should switch those two. By the way, I think it's more appropriate. So you're looking at biological markers. So my question always when I hear biological marker is clinical outcome, clinical effect eventually. Treating biological marker, looking at biological marker only gives me a very narrow type of window. I don't know anything else than that. So that's number one. Can we actually do clinical intervention that will change the clinical outcome and then go back and see if that has changed with the diagnostic, what do you call the diagnostics marker? So that's number one. Number two, have you ever done similar studies in edentulous patients without periodontal disease and where you don't know if, obviously, if the lack of teeth is due to periodontal disease, but even if it is, that inflammation that caused it at that time, at that point, probably is not there any longer. So if you take edentulous patients, what do you find now?
Sure. So I'll address the second one first because that's easy.
Sure.
We actually we asked that same question. We published on it. So we did a study in which the oral surgeons, so one of the issues in Kentucky is we have the highest rate of edentulism of any group in the country. So we worked with our oral surgeons, and we were very easily able to identify a fairly sizable proportion of people before they became edentulous. So we actually sampled them before they became edentulous, and then once we cured periodontal disease by removing all their teeth. And in fact, we could show elevated levels of these inflammatory mediators before the teeth were extracted, and over the period of the next year while we were following them, those inflammatory mediators dropped down. They never dropped to normal levels, to a normal, healthy patient levels. So again, it goes back to the question about this inflammatory phenotype, and those individuals may be reflecting that. So, no, we did not do, no, we didn't follow them long enough to do that. Don't know that one. And then your first one was, sorry, I lost track, your first question. Oh, yes. No, we have not done that. And in fact, I think one of the problems or one of the challenges that we have, if you look at how most of the perio studies are done, where you bring a patient in and you take a sample and maybe 3 months or 6 months later you take another sample, the biology of the disease is happening quick. It's not taking months for this to happen. So what we don't know is having a study designed in which the patients are followed closely enough to actually answer your question, Mike, and that is the temporal nature of that clinical response versus the inflammatory response. And when you're looking once and then 6 months later at another time, you have no idea how that relates temporally to the biology of the disease, I think. So we have not done that. I don't think that's been done yet. Stuart.
Thanks for your presentation. It was excellent. I have a question. You mentioned in one of the vignettes you gave us that you ended up with using some of the machine language learning, and you ended up with higher sensitivities than specificities than you would have liked. And so I wonder if you tried manipulating cost functions to weight the false positives and the false negatives differently to try to get a different sensitivity and specificity. And sometimes that results in a very different model in terms of different variables that come in.
Our biostatistician is working on the existing data because we have a fairly, we have a robust set of markers. They were picked based upon the literature, but now that we're looking at them, there's probably at least 20 of them we'd throw out because they're not particularly useful. But what he's doing is actually asking that exact question, and that is, can we enhance that specificity by looking at the model in various fashions with these different markers? The other side of that is we're coming from the biological side and saying, you know, maybe there are some other markers that we need to add to this or replace ones that are already there. So we're trying to look at it from both sides. Yep. And last but not least, when we talked to him, we said, okay, if we have to make a choice, sensitivity versus specificity, what do we want? We're erring on the side of sensitivity because worst case scenario, it's just treating some patients that maybe don't need treated as well or as much, and it's treating them, it's not going to be of any harm necessarily. Cost, but not harm, yeah.
Great, thank you so much, Dr.
Okay.
Ebersole.
Thank you.